Hello, good day, everyone. We are here for the panel Genetics of Pediatric Diseases in the 32nd International Congress of Pediatrics. First of all, I would like to kindly thank the scientific and executive team of the whole program who made all this possible. I'm Sarah Hanai, and I'm happy to moderate this session with you. Before we start and before we're having the presentation by our expert scientist, I would like to ask Dr. Ehsan Aghai, who is the head of cardiac intensive care units in the Children's Medical Hospital, and is also the head of executive team of the 32nd International Congress of Pediatrics. Dr. Aghai, we are happy to hear you.
Thank you, Sarah. I would like to thank again our speakers, our valuable speakers for their time and for sharing their knowledge with us. On behalf of the Executive Committee of 32nd International Congress on Pediatrics in Tehran, we are all ears and we will be happy to have you with us. And I will be more than happy to keep this collaboration together in the future. Thank you very much. And Sarah.
Thank you very much, Dr. Aghai. Before we go to our honorary speakers, I would like to kindly share a video clip with you, which is a summary of the whole panel of genetics, and we can start. Thank you very much, Dr. Aghai. Before we go to our honorary speakers, I would like to kindly share a video clip with you, which is a summary of the whole panel of genetics, and we can start. Thank you very much, Dr. Aghai. Before we go to our honorary speakers, I would like to kindly share a video clip with you, which is a summary of the whole panel of genetics, and we can start. Thank you very much, Dr. Aghai. Before we go to our very well, happy to getting back to you again. Our honorary invited speakers are Professor Daryl Armstrong Scott, Professor Judy Savige, Professor Olena Grechanina, and also Professor Roberto Giugliani, and also Professor Philip Giampietro. Our first speaker is Professor Daryl Armstrong Scott, who is the Associate Professor of Molecular and Human Genetics at Baylor Medical College, Houston, US. Professor Armstrong, your video and audio are on. We are ready to hear your great presentation.
So I'm not sure if it says the host is disabled screen sharing.
Okay, sure. I think you are now co-host and share your screen.
Okay, we'll give it a try. There we go. So it's a pleasure actually to come and visit with everybody today and talk about genetic testing for individuals with structural birth defects. This is something that has been really a focus of mine for a very long time. Sometimes people wonder, what exactly are structural birth defects? Like, why do we say structural instead of something else? When we think about structural birth defects, we're really thinking about things that actually make a difference in what you can see. And so these are things like cleft palate, cardiac defects, diaphragmatic hernias. These are the type of structural birth defects, and we consider them differently than we think about functional birth defects, like metabolic disorders or neurological defects or seizures, or autism. It's certainly that certain structural birth defects can then cause a functional problem, but we think about them in slightly different ways. So why do we care about structural birth defects? Well, 6% of all children born in the world will have a structural birth defect, and it's a leading cause of infant mortality. over 1/3 of these children will have medical problems throughout their life as a result of their structural birth defect. Why exactly do structural birth defects happen? Well, there's lots of different possible causes. Some of those are non-genetic. For example, deformations where actual pressure makes a difference in how a structure forms in utero. There's also toxin and teratogenic exposures. For these particular causes, genetic testing, of course, is not going to be effective. In fact, it would not even be appropriate if we find this in our histories. What we're really focused on today are the genetic causes, and those can be multifactorial, illegal, or polygenic, where multiple genes are actually working together. But there's also these chromosomal, genomic, and single gene disorders. Currently, our genetic testing is not very effective in finding multifactorial or illegal or polygenic diseases. We're just not really tuned to that. But certainly with the genetic tests that we have, we can identify both isolated and non-isolated cases that we can find a genetic cause. I'm going to focus on just one particular structural birth defect, which I worked on the most, and it will kind of give you a feel for how things have changed over the last, let's say, decade or so. I work on congenital diaphragmatic hernia, which we usually call CDH. It affects about 1 in every 4,000 newborns. And it's basically an abnormal opening in the diaphragm that happens in utero. This is an x-ray of a child that has a diaphragmatic hernia. And you can see that the lung and the heart have been shifted over to one side, and his chest cavity is actually filled with some substance, which ends up being his intestines and stomach. This is an extremely ill infant, and mortality rates are very, very high. When I first started working on diaphragmatic hernia, I mostly worked with surgeons. And this was back in 2003. And I'd say that I'm a geneticist. I'd like to work with you on identifying the causes of diaphragmatic hernia. And over again, they said, but Daryl, CDH isn't genetic. And of course, I was talking to surgeons who are thinking about things perhaps in a different way than a geneticist does. But they'd point out that, hey, most of these kids don't have any family history of diaphragmatic hernia. And aren't isolated cases associated with a very low recurrence risk? And I said, yes, indeed. But there's a counter argument, which is that we do find syndromes where diaphragmatic hernia is a part. Those are genetically caused. We do see some families that have multiple affected individuals. We have mouse models where we can knock out individual genes and get diaphragmatic hernia. And we know that certain genes play a role in certain pathways, and those seem to be important for diaphragmatic hernia. And so I said, you know, it looks like you'll need a little bit of convincing. But my goal is to find new genes for diaphragmatic hernia, and hopefully along the way, I'm going to improve clinical care. And so they agreed to help me out and see what we could do together. The first thing that we did was we said, well, if there are genes for diaphragmatic hernia, then maybe we can use just even the cytogenetic data that we already have to show that certain areas of the genome are more likely to be deleted or duplicated in kids who have diaphragmatic hernia. And that's what's shown on this particular map. One of the questions came back, well, what if this is just what's really common and you're not really seeing diaphragmatic hernia genes in these areas? And so we did the same thing for a different structural birth defect, esophageal atresia, tracheoesophageal fistula, and the pattern was quite different. In fact, when you look at the overlay, only about the 21 different areas that were for diaphragmatic hernia, only 2 were the same for esophageal atresia, tracheoesophageal fistula. So we knew that there were probably genes in each one of these areas that were important for diaphragm development. So then we started to focus on specific areas. One of the areas that we first focused on was on chromosome 15, where we had multiple hits, multiple deletions in this area, and we wanted to find the gene that caused that. One of the partnerships that helped us to do that was this particular infant. This was a prenatally diagnosed infant that had diaphragmatic hernia and also a complex congenital heart defect and a small cerebellum. And amniocentesis was normal. And the physician that was in charge of this case said, hey, Daryl, do you think you could find something more than we could find on just chromosome analysis? And so we ran a microarray. This is back in the very old days when we only had 44K arrays. Now we routinely use arrays that are 10 times as good, if not more. But even in this old array, you can see that there's definitely a duplication on chromosome 2 and a deletion on chromosome 15. That was really important, not only because this child carried a very, very small deletion on chromosome 15 compared to others, but also was important for this child in particular. because it said that this child was likely to have an unbalanced translocation. But we wanted to find out what was the gene on chromosome 15 that was important. Using this child's DNA and results with another child's DNA, we found a little tiny area of overlap that contained only 9 genes. At this very same time, there was a researcher here at Baylor College of Medicine who was working on a mouse model. And in that mouse model, they found that NR2F2 deficient mice had diaphragmatic hernias. And here you can see the diaphragm and the stomach and liver popping through. And this is the lung that's been compressed. And then you can see the heart and the other lung have been pushed over to one side. As it turns out, this is the cause of a lot of the children's diaphragmatic hernias who have deletions on chromosome 15q. The next thing that we went back is we went back and said, hey, we found the cause of this child's diaphragmatic hernia. But it's important to also check the mother and father to see if they are carriers of a balanced translocation. And so indeed, we checked that, and we found that the mother was a carrier of a balanced translocation. This then allowed that surgeon to go back and talk to the family and say, you're actually at very high risk of having another child that has a chromosome abnormality because you are a carrier. And so in this case, not only did it help us to identify a new gene, it also helped this particular family. We went back then and talked to surgeons and said, hey, anybody who has a diaphragmatic hernia and another defect, or what we call CDH plus, should get a chromosome microarray. This case and many other cases helped us convince that, and very soon, everybody who was having CDH plus was getting microarray analyses. Then the question came, well, Daryl, what happens about individuals who have isolated diaphragmatic hernia? They can't be in the same boat. Well, then we had this particular case. This was a 2-year-old male that had radial ulnar synostosis and a diaphragmatic eventration. An eventration basically is a lifting of the diaphragm, not a complete hole. But as you can see, this is the normal diaphragm on this x-ray, and then there's this bulge in the other side where the muscle is weak and the intestines are actually creeping up into an area that again should be preserved for the lung. This is the intestinal outline. In this particular case, we said, well, we would run an array, and we did so. And we found that this child carried a single gene deletion of a gene called ZFPM2. That was important because we'd seen another case of ZFPM2, which was then called FOG2, in a case of a child where both the mouse model and a child had a change in this gene and had diaphragm problems. And so we assumed that this was causative. We then went back to this family, actually visited them in their home and said, well, to prove this, we would like to prove that this is the only child in the family that has that change. To our surprise, the father was also found to have this change. We said, well, maybe he has a diaphragmatic hernia and maybe it's just small and it hasn't been diagnosed. But this father had actually been in an automobile accident, and he'd had a complete body CT scan after the automobile accident, and it had shattered his spleen, but his diaphragm was intact. This was definitely a person who was unaffected. We then had another case that came from a surgeon that we knew where there were 2 children who had diaphragmatic hernia. One of them had a 2-vessel cord, but again, this brother, his older brother, had already died of diaphragmatic hernia. And then he sadly died of pulmonary hypoplasia later. Well, when we did arrays on them, we found that these 2 children also had deletions of ZFPM2 and a nearby gene that we don't think is actually causative of the hernia. But again, it showed us something that was important, and that was that we can have multiple children in a family that have ZFPM2 mutations. In this particular case, we then said, well, what about the mother, the parents? And we found that indeed the mother was also a carrier of this same change. That's why she had 2 affected children. So we learned from this that we can have both isolated CDH and isolated diaphragmatic eventurations that are caused by this gene. It causes it in an autosomal dominant pattern with incomplete penetrance. And indeed, this still remains one of the genes that we see on a regular basis when we have 2 or more children in a family that have either cardiac defects or diaphragmatic hernias or both. And so based on these and other results from other genes, we said, you know, really all individuals with diaphragmatic hernia should get a chromosome microarray analysis. It's relatively cheap, it's easy to do, and sometimes it makes a complete difference for families because this, again, has a very high recurrence rate and can actually run in multiple individuals in a family. Well, and then time went on and we've started to work with exome sequencing. Exome sequencing data gave us a very rich ability or great ability to identify these genetic changes. And we started using them for all kinds of individuals with multiple congenital anomalies. And basically, if we did find a clear diagnosis and the microarray was negative, we would move on to exome sequencing on a routine, regular basis. And we had high diagnostic rates of 25 to 35%. Surprisingly, though, the same thing was not true for the surgeons that were working with me on the diaphragmatic hernias. They were not ordering this on a regular basis. And so they were ordering the microarrays like we had asked them to. But we said, well, is diaphragmatic hernia somehow different? These children are typically cared for by a different group of doctors. And so again, why are they missing out on this type of testing? One of the questions came, well, maybe this is not really a good test. Like maybe it doesn't catch as many of the diaphragmatic hernia children. And so what we did is we did an analysis of 12,000 individuals who had a whole exome sequencing. We found 77 individuals that had diaphragmatic hernia plus, so diaphragmatic hernia and one more unrelated disorder. In that group, we found that we could get a diagnostic rate of 38%. So 29 out of 77 got a diagnosis. And then if we just thought about provisional diagnosis where we're not sure if it really is the cause, we got an additional 9%. So indeed, this is something that works for diaphragmatic hernia patients. In fact, perhaps works even better than some. They said, well, maybe is that really like, can you apply that to all structural birth defects? So far, we've done cleft lip, which was, again, 23% diagnostic rate and 12 provisional. Cleft palate was 29 and 17. We have both cleft lip and palate, that's 29 and 18. And again, these are cleft lip and palate plus, so they have to have some other structural birth defect. And then if we do it for esophageal atresia, tracheoesophageal fistula plus, we get 18% and 9%. And so again, this does seem to be something that is true across the board for structural birth defects. If you see two structural birth defects in the same person, you should really consider also getting whole exome sequencing. The next thing we wanted to say is, well, can we still discover new genes for diaphragmatic hernia or perhaps other structural birth defects? We typically do this by gathering a whole bunch of patients together and saying, well, did they have certain defects? This works great if your defect has a high penetrance. But could we do the same thing using exome sequencing for low penetrance diseases? To do that, we would have to have a different approach. So what we did is we took clinical exome sequencing data, and then we said, well, we're going to pull out only the patients that have the phenotype of our interest. For example, diaphragmatic hernia plus. We're then going to get three different types of patients. One, well, we already know that the gene that we found in the whole exome sequencing data, we already know that that gene causes diaphragmatic hernia. We'll get some where maybe the gene doesn't cause diaphragmatic hernia and it just happened by chance. In other words, we found something, but it wasn't the cause. And then of course, we're gonna get what we really want, which are new disease genes that cause the phenotype. We say new disease genes because again, this is clinical exome sequencing data. And so this is actually based on the reports that go back to physicians. And so some diagnosis has been made in which a human disease gene has been identified. The hardest part for this was actually trying to determine how do we differentiate between the ones that are real and the ones that are there just by chance. And so we thought about that problem. How could we differentiate between those? Well, one of the possibilities is we expect that all these genes will be expressed in the diaphragm. We also might have published reports in the literature that link diaphragmatic hernia with this particular disease gene or this particular disease entity. We also can have mouse models that have diaphragmatic hernia. But then the last piece is something that we worked on, which was, could we use machine learning to help us? The machine learning is really based on a premise, and that's that CDH genes that we're going to discover are going to be similar to CDH genes that we've discovered in the past. They may be similarly annotated or be expressed in the same tissues, or maybe the protein products interact together, or maybe they're targeted by the same microRNAs. They may be regulated by the same transcripts or transcription factors, have similar epigenetic modification patterns, and also may cause similar defects in mice. The good thing is that we have knowledge sources that are publicly available for all of those things. And so we made a machine learning program that actually goes into these areas, pulls the data, and then we can compare diaphragmatic hernia genes from the past to new genes. To do this, we have to first have a training set of genes. Then we do some validation steps. This was our training set, which are all known genes that cause diaphragmatic hernia. We then did what's called leave one out cross-validation with our machine learning. Basically, the idea is that you train the machine learning program, but you do so by taking one of the genes out of the set, running the program, and then scoring it. So in this case, chat got a score of 91.4%, which is really good. We then put that gene back and do the next gene and score it. This is called leave one out. And so in this particular case, DNase2 gets a 92%, the next gene gets to 97.6%, and then we graph that. This is the graph that comes from that. These are all the different ways that we were looking at genes and how they compare. And then the black line is the mean of all those scores. That's what we're going to use to look at all the different genes and see whether they're likely to cause diaphragmatic hernia or not, based on the way they look or compare to other hernia genes. If this machine learning program was just doing things by chance, it would follow along this line. So the area under these curves shows how good the learning algorithm is working. We then said, well, let's do a second validation. So we took a bunch of CDH genes, CDH candidate genes that were not 100% known to cause hernias in humans, and said, well, how did they score? We expected that their scores would be high because some of them would be real. Well, we found that the median score for this group was 95.5%, with all but one scoring greater than 50%. So this says our machine learning algorithm is working. We then said, okay, let's take a look at our diaphragmatic hernia data. We found several different things that were interesting. First, EP300. This had a machine learning score of 94.7%. We found 2 individuals in our cohort that had changes in this gene. It causes Rubinstein-Taybi syndrome 2, which I don't usually associate with diaphragmatic hernia. But this gene is expressed in the diaphragm, and there are other cases in the literature that said Rubinstein-Taybi causes CDH. FOXP1 causes a mental retardation syndrome. But our machine learning score says it's also 96.9%. It is expressed in the developing diaphragm in mice, and we can again find other cases in the literature. SMARC-CA4 causes Coffin-Cyrus syndrome 4. Machine learning score at 93.7, expressed in the diaphragm, other cases in the literature. This probably also causes diaphragmatic hernia. SMARC-C2 is another form of Coffin-Cyrus. Again, machine learning score 89.9%, expressed in the diaphragm, other cases in the literature. This was the surprise. ALG12 causes a congenital disorder of glycosylation. As it turns out, several of these type of genes cause diaphragmatic hernia. Well, the machine learning score was only 48.2%, but we found 2 people in our study that had this. It's also expressed in the diaphragm. The reason why we think we have a low machine learning score in this particular case is because this is a relatively new gene and it's not well described in our knowledge sources. These are all the different genes that we identified in this particular study that had some evidence that suggests they might be diaphragmatic hernia genes. Thank you again for listening to this particular talk. I appreciate spending some time with you. I hope that you were able to find some new stuff that will be useful to you and perhaps think about how we might attack things in a different way in the future. Thank you so much.
Thank you very much, Professor Armstrong. We enjoyed your presentation very much, and thank you for the informative lecture that you presented. During the past few decades, I'm sure that there were many advancements in genetic testings, so the etiology of many diseases were detected, and we hope for a better future and prognosis for all the genetic diseases. Thank you once again, Professor Armstrong. So we can now move to our next speaker, Professor Judy Savige. Professor Judy Savige is the Professor of Medicine at the University of Melbourne, Australia. We are ready to hear her presentation.
Hello, I'm Judy Savige, and I'm going to give a talk on the genetic causes of hematuria in children. I have to emphasise that I'm an adult physician, so my point of view is going to be from the point of view of Alport syndrome in adults and the use, really, that examining the mother may be in making the diagnosis in a child. So Alport syndrome is an inherited kidney disease characterised by hematuria, end-stage kidney failure, hearing loss, and ocular abnormalities. What we understand now is that Alport syndrome is much more common than was previously thought, and probably affects about 1 in 2,500 members of the population. Thin membrane nephropathy, or the carrier state for autosomal recessive Alport syndrome, sometimes known as autosomal dominant Alport syndrome, affects about 1% of the population, so 1 in 100. As far as a diagnosis is concerned, genetic testing is the gold standard. So that while you might suspect Alport syndrome on the basis of hematuria and a family history of hematuria or end-stage kidney failure, the definitive test is genetic testing. However, if genetic testing is not available, lamination or thinning of the glomerular basement membrane is also useful. I want to talk today a little bit about extending the phenotype for Alport syndrome and how many people with FSGS have Alport syndrome or a mutation in the Alport genes, people with cystic kidney disease and familial hematuria from other reasons, for example, IgA glomerulonephritis or end-stage renal failure, may also have Alport syndrome, a mutation in the Alport gene. So Alport syndrome has 3 genes that it is associated with. X-linked disease is associated with pathogenic variants in the COL4A5 mutation found on the X chromosome in about 85% of patients. Autosomal recessive Alport syndrome is associated with 2 variants on opposite chromosomes in the COL4A3 or COL4A4 genes, and that's found in 15% of the population. Autosomal dominant Alport syndrome or thin membrane nephropathy is due to 1 variant in the COL4A3 or COL4A4 gene. As I mentioned, it's the carrier state for autosomal recessive Alport syndrome. And these people do not usually develop renal failure. They don't have ocular features or hearing loss. So these 3 genes, the COL4A3, 4 and 5 genes, code for the alpha 3, 4 and 5 chains of type 4 collagen. And together they form a single molecule that is the major constituent of the basement membranes of the glomerulus, the cochlea and the eye. And this is the reason why you have the combination of clinical features in Alport syndrome. So basement membranes are affected with mutations in these genes, and there is a switch. So children up to the age of, it's a bit unclear, but between 2 and 5, a switch occurs from different genes coding for the alpha 1 and alpha 2 chains of type 4 collagen to the alpha 3, 4 and 5 chains of type 4 collagen. And that's why these children develop hematuria or usually detected at about the age of 6. Mutations in each of these genes affect the corresponding chain, but what happens is that the whole molecule or trimer doesn't form properly, and it's replaced by this more primitive collagen molecule, alpha 112 network, and this is more degradable. And so this is the reason why you have a morphation appearance of the glomerular basement membrane in Alport syndrome, and with successive episodes of repair, why it becomes laminated. In addition, the abnormal basement membrane in the glomerulus results in the loss of the overlying cells or podocytes, and secondary FSGS develops. So here's an example of, down the bottom at the left, a normal glomerular basement membrane and a thinned basement membrane in the middle, and on the right, a split and laminated basement membrane. So the different types of Alport syndrome, I've just summarised in the table here. X-linked is 85% recessive and 15% and dominant in about 1% of the whole population, so much more common. and different numbers of mutations are required. But this also means that there is a difference in the presentations between males and females. For example, with X-linked disease, the males will usually have severe disease. They'll have kidney failure, hearing loss, abnormalities of the lens and the retina and the cornea, whereas the females are much less likely to develop renal failure, but they have hematuria, hearing loss, and some subtle changes in the retina. In contrast, the clinical picture in autosomal recessive Alport syndrome is exactly the same in males and females, and it's identical to the picture seen in males with X-linked Alport disease. And as I've mentioned before, autosomal dominant Alport syndrome or thin mass basement membrane nephropathy is usually associated just with hematuria, and only at the most 10% develop kidney failure, and there's no hearing loss or ocular or eye abnormalities. So this table describes the diagnosis of Alport syndrome and when the clinical features develop. I've included it to show you that it's quite complex, and the sensitivity and specificity are not at the level that we'd really like for a clinical disorder. But they do compare with genetic testing, which has a sensitivity of about 90% and a specificity of at least 90% too. So it's possible, we usually suspect Alport syndrome clinically, but the definitive diagnosis is made with genetic testing, and if genetic testing is not available, with a renal biopsy. However, you may not want to do a renal biopsy in the child, and therefore it's a good idea to have a look at the mother who comes in with the child to the clinic. So why do we suspect Alport syndrome? Because there's persistent hematuria, the family history of hematuria or renal failure, and sometimes we can demonstrate hearing loss at a young age too. Examination of the mother is very useful because in X-linked Alport syndrome, most boys will have inherited the disease from their mother. De novo mutations occur in 15% of children only. And so where the mother is affected, she's more likely to have hematuria, and she might have proteinuria because this develops in adulthood, and she may have a hearing loss. She may have a peripheral fleck retinopathy, and her renal biopsy is likely to be abnormal with some regions of GBM lamination. But I want to emphasise that many individuals with Alport syndrome are undiagnosed, and the reason for this is that they have atypical features or they haven't been examined for those features. So they may have end-stage kidney failure, and in this situation, the renal biopsy is just going to show a scarred kidney. It's going to be unhelpful diagnostically. They may have been diagnosed with another disease, for example, FSGS, where up to 30% of the adults actually have a mutant Alport gene. Or there may be women who have a milder phenotype with Alport syndrome and just have hematuria. And in this case, it's very difficult to distinguish them from people who have thin basement membrane nephropathy. Alternatively, they may have autosomal recessive Alport syndrome, where there's typically no family history of renal disease. So how common is Alport syndrome? The studies that have described it say that it's rare. A study from the United States says it occurs in 1 in 5,000 people, from Sweden 1 in 17,000, and Finland 1 in 50,000. And a study from Australia suggested that it's less than 3% of all adults coming to renal replacement therapy. The problem with these studies is that they're usually derived from hospital-based series that were performed before widespread genetic testings become available, and the true prevalence is actually unknown. So what we did was to go to a normal variant database, to the NOMAD database. This isn't actually a normal variant database. It's from some early studies where people underwent exomic or genomic sequencing, and they were sequenced actually as part of disease-specific or population genetic studies. But a large proportion of those people are actually controls, and so they will be normal. And none of the people who were recruited for the NOMAD database actually had a known renal disease. So it's a reasonably unbiased cohort. and it did exclude people with severe paediatric diseases and their first-degree relatives. And what we did was to use the ACMG criteria to try to distinguish how many of the variants seen in the COL3A5 gene were likely to be pathogenic using the American College of Medical Genetics criteria. And what we found was that in this cohort of about 140,000 people, we found about 88 likely pathogenic variants. And this suggested that the minimum prevalence of X-linked Alport syndrome is about 1 in 2,500. Now, this is not an exact prevalence because it doesn't include already diagnosed individuals who won't have been included in that cohort. And we looked very specifically at glycine substitutions, which are a very common kind of mutation found in Alport syndrome. And so you might be saying, well, how come so many people were undiagnosed? And we went back and had a look, and we found that those people who were undiagnosed had at least one mitigating factor. So there is something there that made their disease milder. So they were female. The mutation was found in the first 20 exons. It was adjacent to an interruption in the collagen sequence, or there was a substitution with an amino acid that had a less severe effect on the phenotype. So there were reasons in all cases why these people had not been detected clinically. We did the same technique for autosomal recessive Alport syndrome and thin basement membrane nephropathy. And we showed that thin membrane nephropathy, we confirmed it occurred in about 1% of the population. And we also showed that X-linked autosomal recessive Alport syndrome occurred in about 1 in 90,000 people. Diagnosis of X-linked Alport syndrome. So I'm going back now to talking about this diagnosis in women. With X-linked diseases, the disease or the mutation will be twice as common in women as in men. And that means for every man with X-linked Alport syndrome, there's going to be 2 affected women. And if we just have a look at these 2 pedigrees, you can see that women are more common in the offspring. So a man will have all of his daughters affected and none of his sons affected, and a woman will have half of her sons and half of her daughters with the mutation. So X-linked Alport syndrome in women is often overlooked, and especially with cascade testing or investigation of other family members, the women are not necessarily brought in for investigation. So most of these women will have hematuria, and 15 up to 30% will have end-stage kidney failure by the age of 60. Now again, our experience in Australia is that it's more likely to be 15%, but it is worthwhile knowing if a woman is affected for other reasons too. So in women, the likelihood of renal failure doesn't correlate with mutation type, and it may be that coincidental features such as hypertension and obesity are more important. And this is, of course, because of the means of inheritance in women with X-linked disease, that it's lyonisation. It's not half of all of the cells. All of the cells have half of the expressed protein in it. With women, hearing loss is common in middle age, and often the women don't know to expect it. And a peripheral retinopathy that doesn't affect vision is also very common. So it's important to know if a woman has X-linked Alport syndrome for her own sake and her risk of end-stage renal failure, but also because her children will have a greater risk of renal failure than the offspring of the immediate offspring of an affected man, because he will only have daughters, whereas she is likely to have a son, or half of her sons will be affected. Diagnosis of autosomal recessive Alport syndrome. It's much less common than X-linked Alport syndrome, and except where there's a consanguinity. And why would you suspect autosomal recessive Alport syndrome if the parents are consanguineous? If there's an early age onset of renal failure, if there's a girl or woman with Alport syndrome and end-stage kidney failure at a young age, perhaps in her teens or 20s or 30s. If a woman develops lenticomas, one of these unusual eye manifestations, or if there's sporadic disease. So nobody else in the family gets renal failure, although they might have hematuria. So genetic diagnosis for Alport syndrome, this represents the gold standard. It's about 90% sensitive for pathogenic variants, and these will occur in the COL3A5, COL3A3 or COL3A4 genes. And I've added in some extra genes that it's possible to look for if you can't find mutation in one of these genes. But these genes don't encode for Alport syndrome, but for other conditions that might be mistaken for Alport syndrome. If you can't detect a genetic mutation for Alport syndrome, then the variant may be a deep endromic change if you've used exomic sequencing, or it could be in a non-canonical splice site. But most of the variants in Alport syndrome are glycine substitutions in intermediate collagenous sequence of the alpha chains. And the pathogenicity of non-glycine substitutions is harder to interpret. The advantages of genetic testing are that you get an accurate diagnosis. You can work out the mode of inheritance. You can work out if it's Alport syndrome or thin membrane nephropathy in, for example, women. There are some features of the variants that will help you to predict the age at onset of end-stage renal failure from mutation type. And this variant may be used to inform reproductive planning, whether the person is likely to have an affected child or not. And it will help determine the treatment type. For example, if somebody has a variant that is associated with early onset renal failure, then I think we all feel that aggressive treatment is warranted. So, and it also will ensure that an affected family member is not affected, can't be used as a kidney donor. So the major mutation types are the same for the COL3A5, COL3A3 and COL3A4 variants. Stop codons are about 10%, splice variants about 10%, frame shifts about 20%, and missense variants about 60%. The mutation features associated with severe or mild effects. Severe effects are nonsense frame shift or splicing variant, and a glycine substitution with glutamic acid or aspartic acid. And the milder variants are similar. It can be used by a laboratory. De novo mutations, about 15% of all pathogenic variants occur de novo. So there's not another family member who has it, but it is important to make sure that the mother doesn't actually have mosaicism and is actually affected. So clinical features do correlate with the mutation type, and so a missense is a milder mutation and is associated with a later age at onset of renal failure than, for example, a severe mutation. It's a truncating mutation. Hypertension also is less common with missense variants than with the severe truncating variants. And hearing loss is also less common with missense than with truncating variants. The hearing loss in Alport syndrome is not just the high range loss, which is demonstrated in the upper diagram, but there can also be a mid-range loss of hearing, as demonstrated in the lower diagram. The ocular features in Alport syndrome affect the cornea, lens, retina. In the cornea, there can be recurrent episodes of corneal ulcers, so the person gets gritty red eyes on waking or after too much screen time. The posterior polymorphous corneal dystrophy, in our experience, is very uncommon. The lens abnormality is lenticonus, which can be treated with lens replacement and occurs in about 30% of patients. And the fleck retinopathy doesn't affect vision and occurs in up to 50% of affected individuals, including men and women. And very rarely there's something more severe affecting the retina, for example, a giant macular hole or maculopathy. So this is just to show you some of the abnormalities that can be seen. If you look at figure D, this is the picture of posterior polymorphous corneal dystrophy, and B is a slit lamp photograph showing the same thing. And if you do specialised corneal tests, you can see that there's a very similar phenomenon happening as happens in the kidney, with loss of corneal cells lying directly above the affected basement membrane. This isn't useful as a diagnostic test. Anterior lenticomus is due to thinning of the lens capsule and protrusion anteriorly of the lens, and you get what is called an oil droplet seen on the red reflection, and even with an ophthalmoscopy you can see this. This is not particularly common in about 30% of patients. In contrast, the fleck retinopathy is very common and might just look like a reflection from the retina, but you can see that area sparing the macula. But around it, there's a lot of flecks which become confluent, and that is the central fleck retinopathy. And in the picture at the bottom on the left, there are confluent flecks, and that's the peripheral fleck retinopathy. In the picture at the top right, there's a depression around the area of the macula, and this is macular thinning, which is seen in men with X-linked Alport syndrome and in men and women with Alport syndrome. In the bottom, you can see another picture of the peripheral fleck retinopathy. And these pictures just show you how the fleck retinopathy is much more obvious with a black and white image. And again, this is showing you a giant macular hole, how the amount of thinning can progress. And on the right, there's a picture from optical coherence tomography showing that the retina has been completely disrupted. And that lozenge that we see sometimes, the thinning seen on the macula, can be useful diagnostically, but it only occurs in men with X-linked Alport syndrome and in autosomal recessive Alport syndrome. But again, it can be useful in the mother. It can be useful in those two groups, in men with X-linked Alport syndrome and in autosomal recessive Alport syndrome. There's a formula that we use, and this is using the measurements that come from optical coherence tomography. This will indicate that there is temporal retinal thinning. So the ocular features generally don't affect vision, and they don't affect vision irreversibly, but they are useful diagnostically. The lenticonus, the fleck retinopathy, temporal retinal thinning are much more common in an autosomal recessive Alport syndrome. And if you see them, then it's possible to make the diagnosis of Alport syndrome. Just before I finish up, I want to talk about extending the Alport phenotype, because we realise that I've spoken about the classical Alport phenotype, but there's extra features, for example, soft tissue tumours and aortic aneurysms that can occur too. But I've mentioned that the phenotype also includes kidney disease, FSGS, IgA glomerulonephritis and end-stage kidney failure. Cystic kidney disease we're recognising more and more with Alport mutations. These don't usually affect the size of the kidneys. And FSGS, we also know that up to 30% of adults diagnosed with FSGS will have a mutation, often in the COL3 or COL4 gene. And the reason for this is the podocyte loss that we've seen with FSGS. IgA glomerulonephritis, where it occurs in families, can be due to an underlying COL3 and COL4 variant 2. We're not exactly certain why this happens, but it does appear to. And end-stage kidney failure, where you don't know the cause, especially in a younger person, you should be thinking about Alport syndrome. Treatment, what treatment is available? We know now that treatment with ACE inhibitors delays end-stage kidney failure by up to 13 years. And they don't have to be ACE inhibitors. You can use ARBs instead. And the effect appears to be on not just on blood pressure, but on reducing proteinuria and reducing interstitial fibrosis. So who should be treated with ACE inhibitors? ACE inhibitors should be used even before the onset of proteinuria in males with X-linked Alport syndrome and in girls with X-linked Alport syndrome from the time of onset of microalbuminuria. and all individuals with autosomal recessive Alport syndrome from the time of diagnosis. What are the implications of the diagnosis for other family members? Who else should be Alport syndrome, X-linked Alport syndrome, all other affected other first-degree family members should be screened for disease with genetics if you can, but otherwise looking for hematuria, which is about 95% accurate. Can an affected mother donate a kidney to her son with Alport syndrome? We usually counsel women against renal donation. So my take-home messages: Alport syndrome is much more common than suspected, but often unrecognised. For every male with X-linked Alport syndrome, there are 2 women. The clinical features are not limited to hematuria and renal failure. Early diagnosis is important because ACE inhibitor treatment delays renal failure for up to 13 years. There are some other inherited causes of persistent hematuria, but these altogether account for probably fewer than 3% of all cases. Thank you.
Now.
Thank you very much, Professor Savige. We enjoyed your presentation very much. I'm sure that genetic diseases involve not only the patients, but also the family. And I'm very grateful of all your efforts in your great job in genetics and also the kind cooperation that you had with us all this time. So now we can move to our next speaker, Professor Olena Grechanina. Professor Grechanina did a great job and also had very kind cooperation with us. We are kindly listening to her presentation shortly. Thank you very much. I would also like to add that Professor Grechanina is also online, so please feel free to add your questions to the chat box, all the participants, about other lectures that we're having during the session. We will ask any question that you may have about these presentations. Thank you very much, Professor Grechanina. We are ready to hear from you.
Dear Professor Nima Rezai and participants of conference, let me thank you for a given great honor to present our researches. Let me express a special gratefulness to an amazing person, a perfect organizer, talented scientist, whom we all citizens of Kharkiv express love and respect. Your support is extremely important and precious. We introduce to your judgment one of 10 scientific and practical projects, in accordance with which our center is being developed. The silent pandemic of hereditary neuropsychiatric disorders. Olena Grechanina, Yulia Grechanina, Svetlana Poplavskaya, and Daria Shkolnikova. Kharkiv Specialized Medical Genetics Center, Center of Rare Orphan Diseases. Our object is to prevent the expansion of the silent pandemic of neuropsychiatric and neurodegenerative diseases through early, differential, and accurate diagnosis. And today the world is immersed in the problem of virus wars. Viruses attack, and we are not very prepared to defend ourselves. There is another pandemic, a quiet pandemic of neuropsychiatric disorders. Autism, syndrome of attention deficiency and hyperactivity, delayed speech, psychophysical development, mental and bipolar disorders, In a significant number of cases of these diseases, metabolic disorders are the material basis. Autistic spectrum disorder occurs in 1 of 50 children, and as for syndrome of attention deficiency and hyperactivity in 41%, and 1 in 200 children is born with a metabolic disorder. Mitochondrial disorders are recorded in 60% of those with autistic spectrum disorder. Every 20 minutes, a new case of autistic spectrum disorder is registered in the world. Over 5 years, the disease has grown by 194%. And these socially significant diseases motivated selective screening, which changes our previous understanding. The disease of such patients is a Pandora's box in which the secret of its cause is hidden. And the growth of the number of neuropsychiatric, cognitive, and neurodegenerative disorders increases the intensity of negative social problems, disability, early mortality against the background of evolutionary maladjustment. And as you know, the behavior viruses in genome is twofold. One of the types of behavior is that once integrated in the genome, viruses behave as part of it. They don't copy their genetic material. Viruses remain in the form of a provirus. This allows viruses to copy the information along with the replication of the host genome and be inherited. We have registered the key seal through prenatal research. In the 21st century, there is compelling evidence for the holistic effect of the gut microbiome of the human body. It has been shown that vast colonies of bacteria that live and develop in the body play multi-directional role in our life. And Alzheimer's disease, dementia, multiple sclerosis are closely related to them. It is not yet clear in this process what is primary and what is secondary. We state only the fact of the closest connection between genome, virome, and microbiome in diseases that are genetically monogenic origin. Cytomegalovirus, according to Helling, hijacks the immune system, continuing to infect, remaining latent currently for many years. Perhaps other viruses behave the same way. And what we must do to combine the efforts of specialists, parents, society, and authorities in a single consolidated state regional program of assistance to families with hereditary pathology, the efforts of specialists, parents, society, and authorities. And as you can see, patients from the western regions of Ukraine, the north regions of Ukraine, all over Ukraine and other countries, as you can see, this is Ukrainian rehabilitation centers. And as you can see, all these countries listed in our center. And as you can see, this genetic navigator, and we have created the genetic navigator, which provides a vicious circle for families with hereditary pathology with a lifelong follow-up. This allows us to provide evidence of the obtained data. The clinical observations that we have analyzed in our study make up the flow of constantly referred patients and their families from all regions of Ukraine, countries of the near and far abroad, mainly immigrants living abroad. And as you can see, the classical genetic methods have been used in this work. We have a wide range of modern technologies due to our own collaborative research. And this is an international council. In complex cases of pheno and genotypes, the method of international multidisciplinary consultations is used. As you can see, the Skype consultation, in the monitoring process, online consultations after the first personal meeting are widely used. This monitoring method preserves the objectivity of the research and care for the patients. Also, consilium expert council session, as you can see, and parental associations, and as you can see, tables, some neurological forms of mitochondrial diseases which were identified in Kharkiv Specialized Medical Genetic Center for 10 years. As you can see, period, nosology, the following syndromes, diseases, disorders, and for 10 years, as you can see, children and adults. And this table shows you also some nosological forms of neurological pathology identified in our center for 10 years. So it's another table of these nosological forms, and as you can see, the following defects and disorders and syndromes. And as you can see, diagnostic criteria and algorithms for different groups of rare diseases have been used. As you can see, recommended clinical testing algorithm for mitochondrial disorder. So if you have patient with suspicions of mitochondrial respiratory chain disorders, as you can see, the following steps. And identify triggers: infection, perinatal, postnatal, untimely, or vaccination, stress, and also inadequate nutrition and treatment. So as you can see, the most common complaints of patients So working with parental associations helps the center to resolve issues of social care for parents. And the collection of information about patient is carried out in the process of daily monitoring by the group of informational and analytical center, which contributes to the evidence of the obtained data. The total number of patients visits over 10 years was more than 300,000, of which more than 100,000 who first applied. And as you can see, the postgenomic genetic report, this is our attempt to find possible ways of influencing gene expression when using cofactor and vitamin therapy or pathogenetics treatment if it exists. As you can see, this CPT2 carnitine palmitoyltransferase 2, it's protein, and it is transported in the inner membrane of mitochondria, and it oxidizes long-chain fatty acids in mitochondria. The defects in this gene are associated with mitochondrial oxidation of long-chain fatty acids. And this molecular gene function, carnitine or palmitoyltransferase activity, also transferase activity at cell group transfer, and possible effects of gene expression, as you can see, the following acids, and if this zoldronic acid, it leads to decreased expression of CPT2 mRNA, and zinc deficiency leads to decreased expression of CPT mRNA. Also quercetin leads to a decrease, and colchicine decreases CPT2 mRNA expression, and as you can see, trans fatty acids lead to increased expression of CPT2 mRNA. So, for example, information on CPT2 mutation have made it possible to find out the functions of the gene and its association with mitochondrial fatty acid oxidation, and to explain the need to use carnitine in treatment, since the molecular feature of the mutation leads to a decrease of specific enzyme activity. And this this slide shows you used basis and the real story of our genetic complexity. So as you can see, microbiome in genome, it is quite obvious that the host human microbiome is acquired at birth and throughout life as a result of contact with the microbiome in the environment, and the microbiome has its own beneficial functions for the host regulation and improvement of digestion and protection against the attack of pathogenic microorganisms. And the influence of natural selection is also obvious. It acts on certain types of bacteria, improves their fitness and the function of the microbiota as a stable community. And as you can see, the pregnancy, 21st weeks, we heterotox increased lung echogenicity and ventricular megalar when periventricular echogenicity, and also you can see meconium cyst, increased intestinal echogenicity. It's a pregnancy 26 weeks after treatment. As you can see, next slides, pro-inflammatory antiviral cytokinase and risk of cytomegalovirus transmission after primary maternal infection ranges from 20% to 70%. The risk is associated with, by gestation age, the presence of maternal immunity with viral genotype with single nucleotide polymorphisms, and in which the risk of infection is reduced. Also, you can see the pathway of mother-to-child transmission, transplacental transmission of cytomegalovirus in the first trimester. As you can see, 5 stages of this transmission. The first stage is a central nervous system affection. First stage is development disorder. The third stage is the cognitive disorders. Fourth stage, as you can see, it is cerebral palsy. Fifth, sensorineural hearing loss. Sorry, it's 6 stages, and the sixth stage is a vision disorder. And our assumptions about the dominant role of viruses in the development of neurodegenerative and neuropsychiatric disorders is based on the data of Dan Fisher and his colleagues in 2018. And placenta goes viral. Retroviruses control expression during pregnancy. And congenital cytomegalovirus infection with clinical signs in 50% of newborns results in disability. And asymptomatic congenital cytomegalovirus infection in the neonatal period causes disability in up to 15% of children. And cytomegalovirus DNA undergoes reactivation, restoration of viral viability in 95% of seropositive mothers with cytomegalovirus and is stimulated by stress, low immune status, lactation. And as you can see, long-term effects of cytomegalovirus are sensorineural deafness, impaired neurological functions, more often in premature infants who acquire symptomatic cytomegalovirus early. And triggers are the following: combining illnesses, different treatment strategies, low parental care, low socioeconomic status, and also prematurity as such. And as you can see, signs of a viral bowel disease, and it is diarrhea, abdominal pain, fever, rectal bleeding. The following slide, as you can see, researching the holistic effect of the gut microbiome on the human body is one of the largest areas of medical research in 21st century. Large colonies of bacteria play a multidirectional role in our lives. They are closely associated with Huntington's disease, Alzheimer's, multiple sclerosis, post-traumatic stress syndrome, and dementia. And in the 21st century, there is compelling evidence of the holistic effect of the gut microbiome of the human body. A feature of the patients examined by us is the presence of signs of persistent or latent microbial, viral, or mixed infection in 36% of them. There is assumption about the dominant role of viruses and microbes not only as triggers but also as the causes in the development of neuropsychiatric diseases. This idea was supported by Fletcher, and who conducted a study of the prenatal period of ontogenesis. And they also noted that the pointed signs of placentation often depend on proteins and regulatory sequences derived from ancient retroviruses. And the placenta becomes viral and retroviruses control expression during pregnancy. So, as I have mentioned already, we have registered such a cane of seal by prenatal examination. And patient 5 years old, so as you can see, he has delayed speech development, stereotyped movements, echolalia, poorly understands the addressed speech, sleep disturbance, irritability, aggression, bruxism, lack of contact with others, selectivity in food, and constipation. And prenatal period of ontogenesis, the threat of miscarriage and hormone therapy, and in early natal period there were tremor of the chin and arms, disturbed daytime sleep, and in postnatal period this patient had the following data. So he keeps the head from 3 months, roll over from 2 months, and sits from 8 months. And has been running since 1 year and 3 months. So as you can see, the first signs of the disease were noted from 2 and 5 years after weaning. Stereotypy, also at the age of 3 years, autism was established. A gluten-free diet, but with no effect, and lactose-free diet with learning effect. A neurologist in 2018 established bilateral and pyramidal insufficiency, muscular hypotension, which can be regarded as a sign of secondary mitochondrial dysfunction. And as you can see, the diagnosis made by psychiatrists, and treatment B6, nicetyl, homeopathic drugs, but fortunately ineffective. So as you can see, the examination, this patient has shown increased leucine, increased adrenaline, and he carry a PTC, CPT2, MTR, and OCS3, and he has decreased vitamin D. So also disorder of microflora of the gastrointestinal tract, deficiency of tryptophan, serotonin, and also we made nose and throat culture, so also ultrasound investigation with reactive changes in the liver parenchyma, deformation of the gallbladder, signs of biliary dyskinesia, and also ultrasound of the kidneys, metabolic changes. The adrenal glands are not visualized. So this patient had increased lactate, also increased ammonia, and as for amino acids, they were normal. And bacterial metabolites were identified by methods of gas chromatography, mass spectrometry, and we have revealed the following: polymorphism of MTRR 2756DG gene, pathological homozygote, polymorphism MTHFR 1298AG heterozygote. The microbiota was studied while saccharolytic bacteriorat forming bacteria, Rosburgia, Blautia, and Enterobacterium were identified simultaneously with the identification of bacteriotes, and high alpha diversity as a rule indicates a balanced diet rich in gluten and a sufficient amount of protein. The result is normal. And we have revealed hyperammonia, decrease in the level of pyruvate, increased level of lactate, amino acids not changed, dopamine is decreased, and lactate is increased, and also decrease of serum carnitine. Full exome sequencing in the syngenome genome laboratory revealed a likely pathogenic heterozygous variant in the PTS gene. Pathogenic variants in the PTS gene are associated with autosomal recessive BH4 deficient type 1 hyperphenylanemia, and found a heterozygous variant in the CPT2 gene. The pathogenic variant in the CPT2 gene is associated with an autosomal recessive deficiency of carnitine palmitoyltransferase 2. We have come to the conclusion about the diagnosis of this patient. And diagnosis is carriage of CPT2 gene. The pathogenic variant of the CPT2 gene is associated with an autosomal recessive deficiency of carnitine palmitoyltransferase 2. Carrier of 6-pyruvyl tetrahydroprotein synthase PTS gene, intracellular carnitine metabolism disorder, type 2 hyperammonemia, MTRR 2756 GG gene, as you can see. It is maple syrup disease, coma before treatment and after treatment, and it was noted that the majority of children with neuropsychiatric disorders were of multifactorial origin, and only a small part developed against the background of genetically monogenic pathology. Very rare hereditary diseases, examples of which can be 3 cases of maple syrup disease, 7 cases of craniometaphyseal dysplasia, and 7 cases of methylglutaconic aciduria, and others of a comorbid nature. So as you can see, this example of diagnosis: craniometaphyseal dysplasia, Arnold-Chiari syndrome, first mutation, and as you can see, the following data of this patient: unusual head structure, wide bridge of the nose, square shape of the ears, domed skull, so progressive manifestation of anomalies. The bridge of the nose has expanded hypothyroidism. The main, maybe it's also hypoxic ischemic affection of the central nervous system, and the rest one, as you can see. By the age of 2 years, hydrocephalus, severe headaches, anxiety, vomiting, and found known mutation C1161126del, in accordance with the following, as you can see, and it's a heterozygous state. As you can see, this child has Arnold-Chiari anomaly, cytokinetic delay, psychospeech development delay, lack of facial expression, a significantly expanded superficial large caliber translucent vein network of the head, chest, visible through the skin, bright red surface of the palms and feet. The head is sharply deformed in the cranial, and the face, dome-shaped raised skull, hypoplasia of the nasal bones, hyperostosis of the lower jaw, difficulty nasal breathing, and there is no possibility of chewing and correct speech. The mouth is open, optic disc atrophy. So this is a case of complex combined form, and diagnosis, you can see at referral delayed cytokinetic development, a more accurate diagnosis: methylglutacone aciduria, lack of methionine synthase reductase, scopolamine metabolism disorder, increased 3-methylglutaric, 3-methylglutaconic acids, leucine, connective tissue dysplasia, vitamin C deficiency. As you can see, patient 5.5 years old, and another patient 3 and 5 years old. And I want to thank organizing committee of the conference, also neuropathologists and rehabilitologists for mutual understanding and cooperation. Also, I want to thank to our patients who presented us with many diagnostic riddles and required a daily search for truth, for faith and respect, and employees of the Genetics Association for their reliability and dedication. As you can see, this child, it's our patient, and we have a video of this patient, and organizers of this conference will show this video later. Thank you for your attention.
Thank you very much, Professor Grechanina. We enjoyed your lecture very much. I'm also grateful of all your time. And also, I know that you've been seeing all the programs from the morning to now, and I'm very grateful of your time. Thank you very much. So we can now move to our next speaker, Professor Philip Giampietro. Professor Giampietro is a professor of pediatrics and also division director of medical genetics in Child Health Institute of New Jersey. Professor Giampietro will discuss about genetics of arhrogryposis multiple congenita. Professor Giampietro, your video and voice is on, and we're ready to hear your lecture. Should I share your slides, or you may share through share screen? Oh, great. Thank you very much.
Could everyone hear me?
Yes, we can hear you now.
Okay, good. No, well, I guess it's afternoon your time, so good afternoon and good morning or good evening, depending on where you are in the world today. And I did want to thank the organizers of the conference for providing me the opportunity to present an area that I've been quite interested in. And I'll talk now about the genetics of arhrogryposis. And is the slide on full screen, or do I need to, I'm going to put it, yeah. Now,
it would be great if you full screen. No, now it's great,
Now it's on presenter, right. Okay, good. So arhrogryposis is an endpoint with many diverse causes, and I hope I'll really be able to emphasize and communicate that to you as we go along. This was noted early on and depicted in this picture, which hangs in the Louvre by Roberto, called the club foot. And you can see that this individual does have joint contractures. The right arm is flexed and the left arm is somewhat hyperextended. There are also club foot deformities, and it's said that you can see a nevus flamus on the forehead if you're up close. So this is the earliest depiction. Maybe earlier than that has been described, but the term arthro means joint and grip is curved or fixed, and arhrogryposis means fixed joints in multiple body areas. And to make that diagnosis, you need to have 2 or more joint contractions in 2 or more body areas. So you can see the table on the top right that gives incidences of club foot, dislocated hips, and all congenital contractures, but multiple congenital contractures as an entity is fairly rare, with an incidence of 1 in 3,000. And as I said, arhrogryposis is an endpoint with many diverse causes, including, as depicted in the lower right slide, neurologic defects, fetal crowding, maternal illness, connective tissue conditions, vascular compromise, muscle defects, all converge, and one has a limitation of joint mobility in the fetus, and these joint fixations are evident at birth. So really it's comes down to any entity that can cause decreased fetal movement or prevent normal fetal movement that can lead to congenital contractures in the newborn. And this slide also kind of drives that point through. If you look at intrinsic factors, the environment and external factors, the intrinsic factors can be, for instance, neuromuscular types of disorders and leading to muscle weakness, which will cause downstream effects, growth restriction, craniofacial abnormalities, excess amniotic fluid or polyhydramnios, osteoporosis, gut immaturity. And if you have compression due to limited in utero space, that can also cause growth restriction and compression types of features, joint contractures. And if there are other maternal illnesses, that can also lead to akinesia, short umbilical cord joint contractures, pulmonary hypoplasia, pterygia or webs in the skin, and multiple disuse atrophy. Talk about amyoplasia, and that's really the, that accounts for about 1/3 of arthrogryposis. A meaning no, myo meaning muscular, and plasia meaning growth. So really a compromise of musculature growth. And this occurs in about 1 in every 10,000 births, and it is rare. Generally there's symmetric positioning of the limbs with equinovarus foot deformity and extended elbows, absent muscle development, as I'll show you in other slides, midfacial hemangioma, and normal intelligence. There is a good response generally to early physical therapy, and about 10% of individuals with amyoplasia have abdominal structural abnormalities. Amyoplasia appears to be, increased in one of identical twins. This was established by Dr. Judith Hall. These are twins here earlier and later in time, and these are different twins here. And you can see that this twin this corresponds to this twin and is smaller than the unaffected twin brother. You can see the arm is extended there as well. And in these two twins, this brother has contracture of his left arm and tends to wear more oversized clothing to hide other contractures that he has as compared to his unaffected twin sibling. So amyoplasia is generally a sporadic disorder and has not been observed to recur in siblings or their offspring. There is an association of vascular-related abnormalities, and these can include gastroschisis, ballotresia, deficiency in abdominal with or without thoracic wall musculature, and digital abnormalities, as you can see in the lower right, and umbilical cord wrapping, as you can see here in the left lower frame with the encircling on the elbow here. Here's the baby with amyoplasia. You can see the real deficiency in muscle development, underdevelopment of muscles, contractures of the wrists, extension of the elbows, contractures of the knee, ankle here. Essentially, the facial features are normal. The current theory for amyoplasia is that there is some type of vascular compromise to the anterior cells of the developing spinal cord, which then impinge on muscle development. There have been classifications and reclassifications of arthrogryposis. Now, this is the distal type of arthrogryposis that collectively accounts for maybe 2/3 of arthrogryposis, and these include about 10 different subtypes, of which I'll talk about some, but these types then are also broken down, which leads us with over about 430 some odd genes associated with arthrogryposis as determined bioinformatically by Hall and Kiefer There are classifications: distal arthrogryposis A1, A2, A3, etc., up to 10, and these have online Mendelian inheritance in man, or OMIM numbers, and I'll talk about some of the commonly occurring ones that you may more widely read about. This is type 1, distal arthrogryposis type 1, and you can see there's a suggestion here. You can see the palm on the left is in the hand, which is classic for distal arthrogryposis. There's contractures of the lower extremities, as you can see, clenched fists, overlapping fingers, adducted thumb, calcaneovalgus, vertical talus, and equinovarus foot deformity, flexion contractures of distal joints. This is autosomal dominant, and there are mutations in genes associated with proteins of the muscle, including tropomyosin, as you can see, tenascin, heavy chain myosin, and troponin. We'll talk about Freeman-Sheldon syndrome, or distal arthrogryposis 2A, and this child has a classic facial gestalt for Freeman-Sheldon. You can see the mouth is small, the lips are pursed, there is an H-shaped cleft in the chin. There's also earlobes that are attached, a tendency towards the eyes or the palpebral fissures to slant down, a high arch palate, sometimes cervical webbing, contractures of the fingers. You can see here, there's camptodactyly, varus foot deformities, laryngomalacia. People can have dysphagia and failure to thrive in infancy due to the failure of really intake because of muscular weakness in the mouth and difficulty opening the mouth, more of a trismus kind of picture. There is an increased risk for malignant hyperthermia, and this is autosomal dominant with mutations in MYH3, muscle heavy chain, myosin heavy chain 3. This is distal arthrogryposis 2B. This is Sheldon-Hall, and sometimes it's hard to really differentiate Freeman-Sheldon and Sheldon-Hall, but I think it's the mouth and the chin that also really give things away. But this child has some of the features of that, including a triangular shaped face, attached earlobes, prominent nasolabial folds, as you can see here, high arch palate, cervical webbing, distal joint contractures, foot deformities. In some instances, there can be intellectual disability, microcephaly, and some overlapping genes again, troponin, tropomyosin, myosin heavy chain genes, all autosomal dominant. Distal arthrogryposis 9, we've talked about muscle-related genes. Well, this also shows some, again, heterogeneity in causes. Distal arthrogryposis type 9, better known as Beale's congenital contractural arachnodactyly, is autosomal dominant and caused by a connective tissue protein, fibrillin 2. These children here have a classic crumpled ear deformity, as you can see, triangular face, mid-face flattening, dental crowding, arachnodactyly, long, thin fingers, contractures here, flat feet, and there is aortic root enlargement also, or mitral valve prolapse that can be seen, interrupted aortic arch, a VSD, and eye problems such as keratoconus. This is different from mutations in FBN1, which among other conditions are associated with Marfan syndrome. So well, there are 400 conditions, and obviously we cannot go through all of them. I think if I can leave you with an approach, and a lot of this was delineated by Dr. Judith Hall in her survey of 500 families with arhrogryposis and amyoplasia, that really led us to a better understanding of what are the factors and what do you need to think about. Well, elevated maternal temperature during pregnancy of 39 degrees centigrade, drugs, fever, alcohol, exposure to Zika virus, maternal bleeding can all provide a setup for a situation where there is a predisposition to contractures in the fetus. Ultrasound studies can help, and generally speaking, you don't really see a decrease of movement unless the ultrasonographer really spends a lot of time with the patient, up to 45 minutes, polyhydramnios, and there is sometimes an increase of people who do have amniocentesis and undergo prenatal diagnosis, which may be helpful for downstream diagnosis. Delivery, including traumatic fractures, which can occur with arthrogryposis, C-section, if prenatally diagnosed to avoid traumatic fractures, masses, fibroids, twins, placental thickening, lost twin scars, cord insertion abnormalities. So one should think about these in the postnatal history and also obtain all anthropomorphic parameters, including head circumference, weight, and length, hospitalization, surgical history, developmental milestones, and a thorough review of systems. Family history of miscarriages, stillbirths can be important, and birth defects, other individuals with congenital contractures, parental consanguinity, but for amyoplasia, it's an absence of family history of congenital contractures that is important because, as I had mentioned, this is a sporadic occurrence. In our clinic and most genetic clinics, we use a team approach for evaluation with histories and contracting done by a genetic counselor and a clinical geneticist. We do histories, family history, physical exam, and ancillary testing information as well. And we'll provide genetic counseling and pay attention to psychosocial issues. On the physical exam, these are some features that one may look for. I want to emphasize the presence of deep dimples that you can see in these individuals here, shoulders, knees, arms, and looking for micrognathia, palate being arched. In some instances, like Gordon syndrome, there can be a cleft. So a head-to-toe evaluation and looking for contractures, absence of muscle mass, dimples over affected joints, foot deformities, nevus, flamus, and radiographic information may be helpful. One would see also gracile long bones, which are osteoporotic due to limitation of fetal motion. So just remember the theme of motion and what controls the motion, spinal cord, then neuromuscular unit, connective tissue, and the joint itself. We had worked on a paper which was published over a year ago, which looked at investigations that one can pursue. And generally speaking, if one's thinking about arthrogryposis, CPK will be elevated. EMG, nerve conduction velocities will give you high yield for neurogenic form and about 35 to 50% for myopathic forms. We view this as a second-line investigation. Muscle biopsy isn't recommended unless there's a clinical suspicion for myopathy. Spinal muscular atrophy and Prader-Willi syndrome are rarely seen with the picture of arthrogryposis. These children have to be really hypotonic, as is the case also in myotonic dystrophy. A chromosome microarray would be a first-line test prior to whole exome, which is also done. And an exome is really looking at all of the coding units of our genome. So if our genome can be enclosed in a 46 volume set of encyclopedias, as shown here, then each book there would correspond to a particular microarray and look at each of these chromosomes here. And then if we wanted to open up and look closely at pages, one can see small changes, copy number variation with each page as a whole within this chapter of the encyclopedia. And then looking at letter by letter by letter by letter is really doing a sequence either of a gene in a particular page or the entire set of encyclopedias, which is an exome. And we'll talk about what an array and an exome are. An array, again, looks for copy number variation. Here's a chromosome, and we're looking at a chromosome loss or gain in chromosome number 7 as compared to our patient to our control DNA. We always have a control DNA to check as a reference, and then when we mix the DNA of the patient and the control together, we look to see if there's equal hybridization. The orange is the control, the green is the patient, or is there dosage loss, having too much of the orange and less of the green, or is there dosage gain, copy gain, having too much of the green and relative to your control. And a machine will go through each plate. This is a small chip, and this will scan it and we'll look to see if there are real consistent dips, which is dosage loss, or gains, which is dosage gain, copy number gain, around in regions of the chromosome. And they will report back to us if there's significant loss or gain in different regions, which correspond to particular conditions that have already been identified. An exome is the sum of our coding units of the genome, and this is a particular gene, and the gene is made up of coding regions separated by non-coding regions or introns. And the exome actually collectively corresponds to about 1% of our genome, which is seen here in this apple. The other 99% is not looked at in an exome. So we're looking at all the coding units of our genome in an exome. And this is done in a very sophisticated manner where it takes weeks to get the results back. You shear the DNA, and then you end up pulling out those coding fragments and getting rid of what's non-coding. And this requires DNA sequence analysis, and you're sequencing little pieces from different cuts in the genome, and then you have to align them and look at variants compared to a reference DNA. So the possible variations that one may get include 4 different types: normal variations, which are changes in gene that don't cause disease, disease-causing variations, disease risk variations, and unknown or new variations that we just don't really know how to classify. This is what the task of the laboratory, the geneticist in the lab does, and they rely on what a clinician does, which is us and you, to provide features that may give clues to genes that have been identified that are altered, and to give meaning to what this data is. And this is one example of a large consanguineous Israeli family, which shows many individuals affected with a neuropathic type of arhrogryposis. And you can see by the double bars, there's consanguinity here and lots of infected individuals. And this is a very complex but autosomal recessive condition. You can see the contraction on the elbows and knees. And whole exome identified mutations in the ERG1C1, which includes a cycling protein in the membrane, and its possible functional role involves transport between ER, endoplasmic reticulum, and the Golgi apparatus. Now, how do we do these tests? If you're a clinician, you can start with an array if that comes out normal. You can think about doing a distal arthrogryposis or next generation sequence panel. That means that you have a series of genes that have been picked and hand chosen that are commercially available, and that you can just sequence letter by letter by letter that particular gene, all the coding regions and the intron-exon boundaries to look for significant coding regions. So a panel only tests for what a panel has, and there are only 10 genes on this panel. So if we get a negative result, it could mean that our gene of interest was not encoded on the panel. Maybe we need to go to exomes, or maybe the gene has yet to be discovered if we strongly feel that this is genetic in nature, or it may not be genetic in nature. But there is whole genome, and this side-by-side comparison discusses exome and genome. Commercially now, most centers can offer whole exome sequence analysis, and the cost is going down. But like I said, that focuses on 1% of the genome. If we do a whole genome, or WGS, we're looking at everything we would in an exome and more. We're looking at the non-coding regions, which may have regulatory mutations which have been identified, and we could identify that in our patient. It's also looking at copy number variations. So for a whole genome, you're getting several tests in one. You're getting really the equivalence of a high resolution microarray, which goes well below the limits of a light microscope. And you are also doing exome in addition to looking at more than an exome does. So you can see you'll get 20,000 variants with exome. We can't go through all of them. We rely on bioinformatic approaches. With the genome sequence analysis, you get 3.5 times 10 to the 6 million variants. Okay, so when I was starting out this over 10 years ago, and just as a geneticist getting involved with this and my research, I naively thought, oh, if I get a list of variants, I can just go into OMIM and look at the variants and find my area that my gene that corresponds to patients. Well, this is impossible to do because there are just so many variants that you get, and it will take you, a year to just sift through, or several just to sift through 20,000 variants, let alone 3.5 million variants. So exomes are good for highly penetrant, meaning genes that really show some phenotype, disease identification. A whole genome sequence is really good for complex trait gene identification, as well as sporadic phenotypes caused by de novo single nucleotide variants and copy number variants. So one paper or several reviewed arhrogryposis multiplex congenita and identified 33 reported studies using whole exome and whole genome sequence, and the diagnostic yield approached about 60%. Most variants occur in the coding regions of genes to date. Okay, so this slide again shows you the different types of testing, going into targeted testing for sequencing of 1 or 2 genes, that you really have a handle that the patient has these features clinically, and that's all you want to limit. Something like cystic fibrosis, tuberous sclerosis, but then a multi-gene panel is then going into lower specificity. You're lowering your specificity, but you're then getting more of a increased heterogeneity in what you're testing for until you reach the ultimate high heterogeneity and low specificity of genome-wide sequence analysis. So with these techniques, you trade off one advantage for disadvantages, and that. So one needs to consider this when you're coordinating testing. Generally, then we have a genetic counseling process, which involves discussing the patient's results with a genetic counselor and communicating this in a setting where the patient can ask questions and also increase families' understanding of the condition and discuss how the condition can be managed and discuss risk for associated for future pregnancies and dealing with other issues, psychosocial issues to cope with a particular condition that the patient has. And we deal continuously with insurance issues in our practice as well in terms of pre-authorizing genetic testing, and insurance companies generally need to know how this testing will alter case management as well. Then all this is synthesized. The purpose of genetic evaluation also is to provide more specificity and precise risk for future pregnancies, and also to rule out genetic causes in some instances, such as amyoplasia congenita, and provide follow-up information to the family. Current treatment modalities include physical therapy, casting, and monitoring for known complications of the given condition based on what the genetic condition is. This is treatment then, we're not at the molecular level. This is an example of another condition called Escobar syndrome. This is autosomal recessive and due to mutations in the gamma subunit of the cholinergic CHRNG acetylcholinease receptor. Here is the nerve, here is the receptor protein here. But you can see this is the patient, multiple contractors present at birth. Okay, and there is a switch from fetal. Here is the fetal, which results to adult, which results in a gamma to epsilon switch in this subunit here. And this may be a key for unlocking future therapies in terms of making this transition earlier or possibly in utero as well. This is work done by Dr. Hall. I mentioned in the beginning, there are about 430 genes associated with arhrogryposis, and these have now been put into different pathways, central nervous system related pathways, muscle pathways, peroxisomal pathways, collagen connective tissue types of related genes. So it's these genes network that can help with really homing down on diagnoses and hopefully future therapies. Once we get particular genes and clusters and parts of pathways, we can look to see how we can influence this pathway and provide more optimal treatment with patients. I did want to also dedicate this to Dr. Judith Hall, whose pioneering work in this condition has really unraveled a lot of the natural history of arhrogryposis, and it's studies that she led that can really pave the way for improved quality of life and therapies for these families. And thank you.
Thank you very much, Professor Giampietro. We enjoyed your informative lecture very much. And so before we move to the last speech, I would like to mention that there are a few questions. So I will be thankful if you stay with us until the last presentation, and then we can move to those few questions. Well, the last but not the least speaker is Professor Roberto Giugliani. He's the professor of genetics at Federal University of Rio Grande do Sul in Brazil. We are happy to have Professor Giugliani as our honorary speaker, and we're ready to hear his presentation. Thank you very much.
Hello, my name is Roberto Giugliani. I am from Brazil, and I accepted this kind invitation to address you a lecture about novel therapies for lysosomal disease. I will share my screen. 1 minute, okay. So I am from Porto Alegre, a city in the very south of Brazil, where you have a federal university, and I work in the university hospital at the Medical Genetics Center. And we are a reference center for lysosomal diseases for the country. So here are my disclosures. We have around 6,000 genetic diseases. 10% of them are inborn errors of metabolism, and about 10% of these metabolic diseases are lysosomal disease. So why lysosomal diseases are quite important? I would say that despite lysosomal diseases include only around 10% of the inborn errors of metabolism and only around 1% of genetic disease, they concentrate a large proportion of treatable conditions, as we will see during the presentation. So the general way I can present this is that we have genes that codify proteins that convert substrates in product when these proteins are enzymes. So if the gene has a problem, the protein may have a problem, and the substrate may be stored and the product may be missing. In the lysosomal disease, the main problem is the storage of substrate. So, and why this storage is a problem? Because this causes dysfunction of the lysosome, this enhances inflammation, oxidative stress, leads to secondary storage, problems in trafficking, impaired autophagy. So there are a lot of secondary problems that related to storage. And during the presentation, I'll try to answer 4 questions. One, are the available therapies we have long-term experience satisfactory? Will the recently added therapies significantly improve the situation? Will the therapies in development solve all problems? When will come the cure of the LSDs? So let's start for the first question. Are the available therapies we have long-term experience satisfactory? What are these therapies? I would say hematopoietic stem cell transplantation, intravenous enzyme replacement therapy, and substrate inhibition therapy. So hematopoietic stem cell transplantation is a process that we remove normal cells from the bone marrow of the donor, and then we condition the recipient to receive these cells, and these cells will so produce the enzymes that the patient is missing. So this is a quite interesting approach. It is being used for mucopolysaccharidosis 1 for the severe form, Hunter disease, for late onset Krabbe disease, late onset metachromatic leukodystrophy. These are clear indications. Maybe use it as a kind of compassionate therapy for infantile Krabbe disease, late infantile metachromatic leukodystrophy. Efficacy is not proven, but we do not have another alternative therapy. It may be an alternative therapy for mucopolysaccharidosis 2, 4A, 6, or 7 that we have enzyme replacement therapy, but you may try to use bone marrow transplantation, and also alpha monocytosis. What's the idea behind the hematopoietic stem cell transplantation is that providing cells to the patient, you can increase the enzyme activity, and this occurs like this patient with mucopolysaccharidosis 1, and decrease the substrate. So there are some advantages. One-time procedure, you provide a stable supply of enzyme if it's successfully engrafted, and the transplanted cells can reach the CNS, which is quite important. There are some disadvantages. The complexity of the procedure, high cost, depends on the finding of a suitable donor, should be provided in specialized reference centers. There is still a high morbidity and mortality. Is a limited number of LSD indications and a limited effect in some tissues like bone, heart valves, and cornea. Another therapy already established is the intravenous enzyme replacement therapy. You have long-term experience already. Gaucher disease, almost 30 years. Fabry disease, almost 20 years. Mucopolysaccharidosis 1, mucopolysaccharidosis 6. Pompe disease, mucopolysaccharidosis 2, mucopolysaccharidosis 4A. Basically, in the enzyme replacement therapy, we need to make a large quantity of enzyme, and for this you use genetic engineering, and you put the normal gene in a cell expression system, and then you have a large quantities of the protein of the enzyme that are synthesized, then you purify and you administer to the patient every week or every 2 weeks. So let's see the case of Gaucher disease. We see this girl before therapy, a large abdomen with enlarged liver and spleen. And after 2 years of therapy, you see the abdomen is very much reduced, and she grew quite a lot. So it's an effective therapy for some disease, has some advantages, no invasive. You provide a pulse of high amount of enzyme, circulates in plasma with uptake by tissues and organs, and reduces the substrate storage, but has some disadvantage like the high cost. You need an infusion every week or every 2 weeks. You may have infusion reactions, you may produce anti-drug antibodies that may affect efficacy, and there is limited effect in some tissues like the CNS, very important, the bone, heart valves, and cornea. Another approach you already have in place is the substrate inhibition therapy, and this figure illustrates this kind of approach. When you have a normal flow of water and a sink that is working okay, you do not have accumulation of water. But when you have the sink has a problem and the flow is not okay, as you have when you have a enzyme defect, then you have accumulation of water. One alternative is to improve the flow of water by giving an enzyme, and then you normalize this, or reducing the flow, the amount of water that arrives, and this is the substrate inhibition approach. Let's see an example. You have here the Gaucher disease metabolic pathway. In Gaucher disease, you have a block on the beta-glucocerebrosidase, so the glucosylceramide is not converted into ceramide and is accumulated. And one approach you can use is to reduce the synthesis of glucosylceramide by miglustat or eliglustat, and this then we can restore the balance. So this is something you can do in some diseases. It's available for Gaucher disease and for Niemann-Pick C disease. Let's see what results in Gaucher disease. You see this with this substrate inhibition, the spleen volumes go down, the liver volume also go down, the hemoglobin go up, the platelets go up. So it's quite successful therapy for Gaucher disease. So its advantage is an oral therapy, it's convenient, small molecules diffuse easily in the body, reduces the substrate buildup. Disadvantage, again, the high cost, there's lower rate of substrate storage when compared to ERT. So let's answer our first question. Are the available therapies who have long-term experience satisfactory? I can say, despite benefits, not fully satisfactory, as there is a limited number of diseases benefited, limited effect of therapy in most of these diseases. So let's go to the second question. Will the recently added therapies significantly improve the situation? What are these recently added therapies? Additional intravenous enzyme replacement therapies already approved for some very rare conditions like acid lipase, mucopolysaccharidosis 7, alpha-monoacidosis. The intracerebroventricular enzyme replacement therapy, an approach to bypass the blood-brain barrier, providing enzyme into the CNS, is using the neuronal steroid lipofuscinosis type 2. And also pharmacological chaperones for Fabry disease. I will explain in a minute. So the intracerebroventricular enzyme replacement therapy for lipofuscinosis steroids type 2, with a pump and a device, you administer every 2 weeks enzyme into the ventricular space, so directly in the CNS. And the results are amazing. You see the natural history of this disease is a very sharp deterioration after the third, fourth year of life. And with the enzyme, you can keep the functioning of the patient very, very well. But you need to start this therapy very early in the disease. So this is a challenge. This was approved in 2017 for the first time. The advantage is the enzyme reaches the CNS, prevents further deterioration, but the disadvantage is the high cost, the intracerebral ventricular infusion every 2 weeks, and does not revert the sequela already in place. Let's see another approach we have is the pharmacological chaperones or the enzyme enhancement therapy. The aim of this therapy is to make the enzyme you have that may be not working properly because it is not is a protein that is trapped in the quality control of the cell. These proteins, they are synthesized in the plasmic reticulum and have to cross the Golgi and reach the lysosome. If these enzymes are not perfect, the quality control of the cells trap this protein and removes this protein. But it may retain some residual activity if the enzyme was able to get the lysosome. So the chaperones, what they try to have these misfolded proteins to stabilize these proteins and make them reach the lysosome and have some activity there. And in fact, for Fabry, it has been successful. You see the amount of substrate in patients with placebo. These are keep high. In patients with these chaperones, the amount of substrate stored decreases significantly. And so this is something that is very interesting approach, is already in place for Fabry disease, but is a specific. You need to have some genotypes that are amenable for the use of this therapy. But it's a very interesting approach. So it was already approved for Fabry disease in 2016. So it's an oral therapy, it's convenient, it's a small molecule, easily diffused in tissues, has some disadvantage, again, the high cost, and only patients with amenable mutations are benefited. So answering the second question, will the recently added therapies significantly improve the situation? The answer is, despite benefits, not fully satisfactory, as limited number of diseases were added to the list, and also limited effects of therapies in this disease. So let's go to the third question. Will the therapies in development solve all problems? What are these therapies in development? This list does not include gene therapy or genome editing. So additional intravenous enzyme replacement therapy for Fabry disease, for Niemann-Pick B, for Fabry disease. Additional intracerebroventricular or intrathecal enzyme replacement therapy for mucopolysaccharidosis 1, mucopolysaccharidosis 2, metachromatic leukodystrophy. Additional pharmacological chaperones for Pompe disease, for Batten disease. Fusion protein that bypass the blood-brain barrier. In a minute, I will explain what is a fusion protein for mucopolysaccharidosis 1, mucopolysaccharidosis 2, and mucopolysaccharidosis 3A. Additional substrate inhibition therapies for Gaucher type 3, for mucopolysaccharidosis 6, Niemann-Pick C. Approach to inflammation like MPS 6 and MPS 4A. Encapsulated cells are also, we explained this strategy you have been using for mucopolysaccharidosis 1. And also stop codon read-through for MPS 1 and cystinosis. So let's quickly see these new therapies. The intravenous enzyme replacement therapy of pegylated enzyme. You can see here the half-life of the normal enzyme in red and the half-life of this pegylated enzyme much longer. So you can have this standard half-life, and maybe you can give an infusion every 4 weeks. It's very different than have an infusion every 2 weeks. So it's much more convenient if this is proves to be effective. The intracerebroventricular enzyme replacement therapy already approved for lipofuscinoid steroids type 2, but is in clinical development for MPS 2, intrathecal or intracerebroventricular. Also in clinical development for metachromatic leukodystrophy. It's you provide this with a device you place near the lumbar spine, and then every 2 weeks or every week you have to inject the enzyme in the device and do not need to have a lumbar puncture. And you see the results in clearance of substrate in the CNS. This, in case of metachromatic leukodystrophy, the lysosulfatide is very much decreased with this intrathecal enzyme. And let's see now if this translates to clinical benefits to the patient. In fact, our group has performed the first intrathecal enzyme replacement therapy in mucopolysaccharidosis back in 2008, and we published this. And this is something that is, I think, very interesting. But also very interesting is this intravenous enzyme replacement therapy fusion proteins. Is you use the figure of the Trojan horse because it is a way to deliver the enzyme inside the CNS to bypass the blood-brain barrier. We published this a couple of years ago about the use of this strategy. I will explain on this slide. You have an antibody, and you fusion this antibody with the protein the therapeutic protein, and this fusion protein so reaches the blood-brain barrier, and the blood-brain barrier recognizes the antibody and lets this fusion protein to pass into the brain, the CNS, and then we have the enzyme, as it is on the tail of this antibody enzyme inside the CNS. And this really works. You can see here, after 3 weeks administering this intravenous enzyme, you measure the levels of glycosaminoglycans in the CSF, and you see a sharp reduction of this, so showing that the enzyme really crosses the blood-brain barrier. So it's a very interesting approach to the therapy. Also, there are some new enzyme replacement, new substrate inhibition in development. We already had the miglustat and the liglustat to reduce the synthesis of glucosylceramide, and now we have venglustat. And the advantage of venglustat is that it's able to cross the blood-brain barrier, so we can treat some diseases that have some neurological component. So and you see the Gaucher type 3 is a disease that has CNS involvement. This is an animal model. In the wild type animals, you see there is no accumulation of substrate. In the untreated animals, you see large accumulation of substrate. And in the treated animals is very much close to the control. So it's a very promising therapy in development, now presently in clinical trials. Other therapies in clinical trials is odiparcil. It's another approach that makes the substrate more soluble, more easily to be removed. And so this has been used in an animal model of mucopolysaccharidosis type 6. I will show the results in the cornea. You see the cornea, normal cornea, the cornea of the MPS 6 mice, and the cornea of the MPS 6 mice treated with this odiparcil. You see it was removed the glycosaminoglycan, and it's much more closer to normal. So this is also now in clinical trials. Cyclodextrins used in Niemann-Pick type C, as it reduces cholesterol accumulation, should be administered directly to the CNS, presently in clinical trials. And you can see here in the wild type in this in the top curve, and then untreated the animals here in terms, and then you see the treated animals very much closer to the normal mice. You see also the survival is very much improved with the use of this cyclodextrin. So it's also in clinical trials. There are some drugs that have been used, are being used as for inflammation, that they reduce the levels of interleukins and TNF, and may have a role on the adjuvant therapies. One is this pentosan polysulfate. There was a trial in patients with MPS 1 with very interesting results, and this was already published. So there are therapies that may be used along other therapies. We are trying now this drug losartan, that is a drug used for already in the market for other indications. We noticed that there is an aortic root dilatation in patients with mucopolysaccharidosis. Despite the use of enzyme replacement therapy, you see MPS 4A and MPS 6 increase the diameter of the aorta. And so now we are doing a randomized clinical trial to have this, evaluate the efficacy of losartan along with enzyme replacement therapy for this kind of problem. Another approach you have been using is the encapsulated cells. Here you see the capsule where we put inside the modified cells that overexpress some enzyme we want to, they have expressing. The capsule has protects the cells from the antibodies, but this capsule has holes that allow the products to flow in, and the nutrients to flow in and the enzyme to flow out. So we have here the capsules, you see the cells inside, and with electron microscopy you see the holes where the enzyme could flow flow out. We already published this in animal models, and now there is a company, the name is Sigilon, that is using this strategy to treat the human diseases, and they are using this capsule they put on the peritoneum, and the capsule keep for many months. They are producing enzyme. They have some trials on hemophilia and diabetes, and also on lysosomal diseases. And another strategy is the stop codon read-through. It's interesting for some type of mutations. When you have a nonsense mutation, that the translation of the protein is interrupted. So the normal mRNA, you have a normal protein translated, but if you have a stop codon, they have an incomplete protein that is not active. So if you can bypass this stop codon with a drug, you can have at the end a protein that may be not 100% normal, but may have some activity and may improve the prognosis in the patient. So this has been used for mucopolysaccharidosis type 1, and there is one company using it for cystinosis. So it's something that may have a place in the therapy. And I will finish my presentation, talk a little bit about gene therapy. Gene therapy is a hot topic in this moment. We can be in vivo therapy when you have can inject in intravenous injection of a vector carrying your transgene, or a direct injection in the tissue, like in the brain. It is in vivo therapy, or you can have an ex vivo therapy where we remove cells from the patient, you process in the lab, and then you return the processed cells to the patient. So these are two kinds of therapy. The DNA is inserted in cells using vectors, and so you have your gene, your vector, and then you take this to your patient's cells. When you use a virus, you can use a retrovirus, a lentivirus, adenovirus, or adeno-associated virus as a vector. And another thing I want to talk about to you is about genome editing. It has very much on the news in the last weeks, as the Nobel Prize was given to two investigators who designed this process. And this is a very interesting strategy to go to the gene, to the genome, and edit the genome and have a normal sequence of gene in some place that is expressed by the patient's genome. So, and there is a very promising therapy. So regarding, if you go to clinicaltrials.gov, you have a lot of trials going on for cystinosis, Fabry disease, metachromatic leukodystrophy, Pompe disease, mucopolysaccharidosis 1, mucopolysaccharidosis 2, mucopolysaccharidosis 3A, mucopolysaccharidosis 3B, mucopolysaccharidosis 6. So in total, 19 clinical trials for 9 different diseases. And probably if you go today, there may be some further disease. So these are I'll give an example about this lentiviral gene therapy for Fabry disease. It is a therapy that is an ex vivo therapy. You remove the cells from the patient, you process in the lab, and then you give back to the patient. So when you give back to the patients, you see the increase of enzyme activity and reduction of substrate. And if you look at before the giving the cells, there's a lot of substrate in the kidney, and if you go 6 months later, there's a lot of clearance. So it's a very interesting therapy. And in the long term, it seems that it keep working. After 2 years of therapy, you see still a lot of enzyme activity above the normal level. So it's a very interesting therapy. Let's see how it goes. It's being developed for Fabry disease, but also the same company is developing for Gaucher, cystinosis, Pompe, and there are many trials going on. Our group has been using this therapy for genome editing in mucopolysaccharidosis 1. We are still in animal models, but there are already clinical trials using this strategy. So will the therapies in development solve all problems? I would say that with the new therapies in development, most LSDs will have a disease-specific therapy. New therapies will probably stabilize disease and prevent progression. However, the sequela already in place most probably will not be reversed. So when will come the cure of the LSDs? I would say that in few years, we will have therapies available for most lysosomal storage diseases. With therapies available, as sequelae are not reversible, early diagnosis, preferably pre-symptomatic, will become essential. So newborn screening may be the solution for the early diagnosis of lysosomal diseases in a not too distant future. So in few years, most lysosomal diseases will have effective therapy, early diagnosis, but they are still the problem of the high cost of these therapies. So my final message that therapies not only need to be efficient, diagnosis not only need to be timely, they also need to be affordable. Thank you very much. This is my email. You can reach me at any time. Thank you.
Thank you very much, Professor Giugliani. We enjoyed your presentation very much. I'd like to thank all the speakers once more for the time and also their great lectures. We enjoyed very much. So I want to ask a few questions from the speakers. The first question is, I think, from Professor Armstrong, if I'm correct. The question is that what's your strategy for genetic testing of patients with isolated anomaly, I mean major anomaly, and no suspicion for any syndrome?
One of the difficulties that's encountered is the fact that you usually are identifying these children shortly after birth. And so a lot of times there are other comorbidities that maybe only come to play when the child's older. And so often we're seeing in these children in the neonatal intensive care unit. In that setting, it's actually easier for us to get genetic testing than in other settings. And so for severe defects such as diaphragmatic hernia or cardiac defects that are severe, that are requiring surgery, we often obtain both a microarray and also exome sequencing at that point. We found that exome sequencing data, if it yields an answer or if it does not, still helps in patient management in those settings. And so it does depend. If you have a very minor anomaly, we would probably not trigger any genetic testing. But the more severe the anomaly, the more likely we are to trigger that. And again, especially in an intensive care unit type setting, it's actually quite easy for us to be able to do so in the United States.
Thank you very much. Also, there's another question, and it's that some diseases are multifactorial. So how are the diagnostic tests effective in these cases?
Yeah, it's interesting. When we first began our work on diaphragmatic hernia, for example, everybody assumed that all of it was going to be multifactorial and that we would never find anything that was a real substance besides those that are just these syndromic versions that we would be able to identify. But we're seeing that the more you look, the more you find. In other words, the more we actually delve into this, we find that we are finding de novo changes in children that are the cause of their structural birth defects. And again, you say, well, what is the typical? A typical patient that comes to see me in genetics clinic, we're going to try to be able to identify the cause of their problems in about 50% of cases. This is all comers. And so that's a pretty significant portion. So it appears that there's at least a large number of individuals that have these structural birth defects, that it's actually there's a major cause or a major player that can be identified using the tests we currently have. Now you can say, well, what about the other 50%, or perhaps even more in some of the cases? Those can definitely be a multifactorial type of a case, and those will not be identifiable on our genetic testing. The difficulty is a priori, there's no way to be able to tell which ones will fall out and which ones will not. And so our tendency is to go towards testing versus not testing.
Thank you very much, Professor Armstrong. And there's one more question, I think it's for Professor Philip Giampietro. You mentioned in your presentation that there are many types of arhrogryposis. May I please ask if there is any other way than genetic testing for differentiating these types of arhrogryposis?
Thank you. Yeah, prior to genetic testing, a lot rested on clinical diagnosis and recognition of more commonly encountered arthrogrypotic conditions as published in the literature. And one reference book that we use all the time is Smith's, which everyone around the world has. And then there's also different types of databases like POSSUM, for instance, and OMIM as well, that you can do searching on key features and kind of synthesize that. That's not genetic. Problem is there's a lot of overlap and there are many genes, and if I've been fooled a lot of times by thinking that new genes are being discovered all the time, and certainly when you get into conditions that present in the neonatal ICU, like the fetal akinesia, hypokinesia umbrella, some of these, look like known phenotypes, but then some of them do, and they're not due to genes that you think there would be. So it's very tricky, and there's a lot of overlap. So I think genetic testing, I think there's no substitute for a clinical, evaluation and making some hypothetical categories in your head. Is this, going down from brain to spinal cord? Where do you think the lesion could be? Is it amyoplasia versus a distal arthrogrypotic type? And, then trying to subdivide, see what major features are. But, when you're getting down to it, genetic testing can help, and it can help fine tune, and provide a diagnosis or exclude a diagnosis as well. So I think now, I think people more and more are relying on genetic diagnosis to really help, management. And I don't know if that fully answers the question, but it's a
Thank you
hard
very
question.
much. I think you answered the question very precisely. Thank you very much. Also, I'm seeing that Professor Olena Grechanina has mentioned in the chat box that in case you may have any questions about her presentation, it would be kind of you to send her an email, and she will kind of respond you. So before we finish this session, I would like to thank again of all our invited speakers, Professor Armstrong, Professor Giampietro, Professor Grechanina, and also Professor Judy Savige and Professor Roberto Giugliani. They also had very kind contribution in the book series, Genetic Syndromes. We are editing this book with the undergraduate supervision of Professor Marazai. And in case any of you might be interested in drafting any chapters in genetic syndromes, please feel free to contact us, and it will be great if you could have contribution in this great book. And also, I'd like to send a message on behalf of Professor Nimarazai, who is the scientific chief of this panel. He has sent his greetings, and he's also very grateful of your time and also your great lectures. And so I'd like to finish this panel, and I'd like to ask all the participants to join us in the next panel, which is in infectious diseases, and the link to joining that panel is also mentioned in the chat box. Thank you very much, and I hope you for being so great and healthy, especially in this condition of COVID-19, which we are all struggling all around the world. Be safe and happy. Good night and good afternoon, and so goodbye.